Well, I'm really excited to introduce the next presenter this afternoon, Dr. Michale Lakes. Mike is not only CEO, co-founder of Medical Interface Solutions, which he's going to share with us, but when he's not busy being an entrepreneur and starting med tech companies like this, he's an emergency room physician. He's chief staff elect at Kettering Health Systems in Dayton. He's chief of emergency medicine, and he's the medical director. So I know he's got a lot of time on his hands. Mike is going to talk to you about a very important matter in stroke management. And one of the key things that Mike taught me in the past 2 months of working together is that in stroke management, of course, time is brain. And this is very important. Thanks, Mike.
Thanks, Gary. Wow, I don't think I even realized how busy I am until that introduction. Thanks, Gary. But yeah, time is brain. So how many of you know somebody who has had a stroke? Raise your hands. Quite a few. How many of you are confident that you know the signs and symptoms and know exactly what to do if you were to see somebody having a stroke? That's a lot fewer hands. But you're not alone. Our EMS crews, they struggle as well. So of the 800,000 strokes that occur every year in the US, EMS identifies only about 70%. That means delayed treatment, or more often than not, no treatment at all. So as Gary said, I'm an emergency physician. I see stroke patients every day, and I see the devastating effects of delayed or misdiagnosis and mistreatment. And that's why we're building Stroke Connect, and that's an AI-enabled mobile stroke diagnostic and care platform. And that process works to transform the acute stroke care pathway from the moment that symptoms begin. Our algorithm's 91% accuracy, it increases the number of treatable stroke patients while reducing unnecessary and costly evaluation for the hospital system. Great thing is there's no change in workflow for the paramedic. They're going to perform the same standard 60-second evaluation that they do to diagnose stroke in the field. The only difference is they're going to be running our software, Stroke Connect, on the mobile device that they're already using to document their care and treatment. So our software runs on that device and it analyzes the video in near real time, about 1 second of processing time for each second of video. We generate a probability score of the likelihood of stroke, and if that's positive, we connect directly to the neurologist virtually. They then are able to do their full assessment with the assistance of the EMTs in the back of the ambulance. So that 60-second evaluation now can save 60 minutes in time to treatment, and that saves about 120 million brain cells. How many people would still like to have 120 left, right? It's super important. I like to have all of mine. So Stroke Connect is clearly differentiated in the acute stroke care space. The only viable US alternative right now is a mobile stroke unit. Those cost about $2 million to build. They cost about $2 million a year to run, and they're only cost effective in major metropolitan areas. They need about 1 million patients to make it worthwhile. You can see the letters AI down here, Rapid AI and Viz AI. They use artificial intelligence to interpret CT scans to help diagnose stroke, but those interventions only happen after the patient arrives at the hospital. But Stroke Connect starts in the field at the first clinical touch point. We coordinate care across the continuum from bystander to bedside, from stroke detection to TPA injection. And you can see there Rapid AI, Viz AI, EMS vendors such as Stryker or Zoll are potential exits as well for us. We think that the 800,000 stroke patients a year translates into about a $1.26 billion TAM. Our SOM is about $54 million, and that's based on our comprehensive stroke centers and their associated primary stroke centers and stroke-ready hospitals. For a typical hospital system, a $2 million investment could yield an ROI of about $18 to $25 million. And that's based on newly discovered treatment-eligible patients, as well as the reduction in cost of care through unnecessary evaluation, increased length of stay, and those sorts of things. We're confident in our growth and revenue curve. We can be in 400 hospitals by 2032, impacting tens of thousands of lives and creating a data-driven, defensible network effect across pre-hospital and hospital stroke care. And that's with a 90% profit margin. Here's where we've been over the past 2 years with about $300,000 in state grants and with founder funding. We've created our 91% accurate alpha prototype. Late last year, we signed an LOI with a strong Southwest Ohio health network. You can guess who we were talking about. And that network is ready to do our pilot with us right now. And that is why Medical Interface Solutions is asking for a $1.5 million seed round. We need to complete our or execute our pilot. We need to augment our engineering. We need to complete our FDA SAMD regulatory pathway, and we'll need some funding to start our initial commercial operations. And as I said, this is not just AI-enabled CDS. This is a stroke intelligence platform. So we see a total TAM for all these different phases of care or different products of almost $4 billion. So immediately after the acute care product starts, we can then do intensive inpatient hospital monitoring for stroke, rule outs in treated stroke patients, an on-demand remote neurology network, a stroke AED in every church, office building, and gym, and then finally a phone app for the 10 million plus at-risk patients in the US. Have a great team. Gary talked about my skills. My co-founder has 20 years of healthcare IS experience. Our AI developer is exceptional, and you can recognize some of the names over there that have demonstrated success with their previous exits. So thank you for your time and attention. We'd love your help in bringing Stroke Connect to the front lines of stroke care so we can transform the outcomes for stroke patients across the country.